A.K. Henry's approach of femoral hernia is an open preperitoneal approach used mainly for bilateral or strangulated femoral hernia, as it allows good exposure of femoral canal and abdominal cavity. Consider this as a bilateral femoral hernia model where swelling appears below the inguinal ligament lateral to pubic tubercle on both sides. A.K. Henry originally describes lower midline vertical incision mainly used for strangulated femoral hernia. Transverse or Pfannenstein incision is made for bilateral and elective femoral hernia cases. Incision deepened and subcutaneous tissue and superficial fascia of anterior abdominal wall are opened. Anterior rectus sheath is visualized and opened transversely. Rectus sheath is dissected superiorly and inferiorly off the rectus abdominis muscle to create the space. Rectus muscles are retracted laterally to enter into preperitoneal space. Inferior epigastric vessels are seen on posterior surface of rectus muscle and is identified and preserved. This approach provides wide view of pelvic floor and can access both femoral canals simultaneously. Peritoneum is retracted up, bladder is pushed down, and hernial sac is identified entering the femoral canal. Hernial sac is dissected free from its attachments and pulled upwards from femoral canal into the preperitoneal space. If the hernia is incarcerated or stuck, lacunar ligament is carefully incised to widen the ring and release the tissue. We can clearly see the femoral canal bounded laterally by femoral vein, anteriorly by inguinal ligament, medially by lacunar ligament, and posteriorly by iliopectineal ligament of Cooper. Femoral canal is closed after repairing the hernial sac. Hernial sac is opened and contents assessed. If the contents are viable, it is reduced directly into the abdomen. Hernial sac is rotated, transfixed, and excess sac cut. If the contents are non-viable, peritoneum is opened and resection is performed. Hemostasis is checked and sac is allowed to retract. Femoral canal is closed by suturing inguinal ligament anteriorly to Cooper's ligament posteriorly. Usually 3 to 4 interrupted sutures are placed with non-observable suture materials. Alternatively, preperitoneal mesh placement can be done. Care should be taken to avoid injury or narrowing the femoral vein. Now femoral canal is completely closed from above. Rectus muscle is medialized on same side and opposite side rectus is lateralized to visualize the femoral ring. Sac is dissected and repaired and femoral canal is closed in similar manner as opposite side. Both rectus abdominis muscles are now medialized. Anterior rectus sheath is closed transversely using continuous or interrupted sutures with non-observable suture material. Advantages of Henry's approach includes it allows repair of bilateral hernia through single incision and best suited for strangulated and recurrent femoral hernias. Disadvantages includes extensive dissection compared to low approach like Lockwood's and risk of injury to bladder and aberrant obturator artery is high. Subcutaneous tissues and skin closed in layers. This completes A.K. Henry's approach of femoral hernia, and key steps includes high preperitoneal approach through low midline or Pfannenstein incision, dissection of sac and closure of femoral ring by suturing inguinal ligament to Cooper's ligament. Thank you.